Glucose is the final product of carbohydrate digestion in the intestine. Once absorbed, it serves as the body's primary source of energy for essential life processes. Blood glucose levels are tightly regulated by hormones. Insulin lowers blood glucose, while other hormones work to increase it. This balance keeps blood glucose within a fairly constant range. When collecting and handling specimens, several points must be remembered. In whole blood, glucose decreases by about 10 milligrams per deciliter per hour, which is roughly 5 to 7%. Refrigerated serum is relatively stable, but cerebrospinal fluid should always be analyzed immediately. Sodium fluoride, found in gray top tubes, is often used because it slows glycolysis, preventing a rapid drop in glucose levels. The reference values for glucose are also important to note. In fasting serum or plasma, the normal range is 70 to 99 milligrams per deciliter. Arterial and capillary samples usually read slightly higher, about 2 to 3 milligrams per deciliter more. Cerebrospinal fluid glucose values are typically about 2/3 of plasma levels, or approximately 60 to 65%. Whole blood glucose tends to measure about 15% lower than plasma glucose. However, in point-of-care testing, whole blood glucose results are routinely reported as plasma glucose values for consistency. Insulin is produced by the beta cells of the islets of Langerhans in the pancreas. It lowers serum glucose by stimulating the uptake of glucose into cells. Glucagon, secreted by the alpha cells of the pancreas, has the opposite effect. It raises blood glucose by stimulating glycogenolysis, which is the breakdown of glycogen into glucose. Adrenocorticotropic hormone, or ACTH, comes from the anterior pituitary. It increases glucose levels and acts as an antagonist to insulin. Growth hormone, also secreted by the anterior pituitary, raises glucose levels as well. It opposes insulin's effects, and when secreted in excess, as in the condition called acromegaly, it leads to hyperglycemia. Cortisol, from the adrenal cortex, increases blood glucose by stimulating gluconeogenesis, which is the production of glucose from non-carbohydrate sources. Human placental lactogen, produced by the placenta, also raises glucose levels. It functions as an insulin antagonist during pregnancy. Epinephrine, secreted by the adrenal medulla, elevates glucose by stimulating glycogenolysis. In conditions like pheochromocytoma, where there is a tumor of the adrenal medulla, excess epinephrine can cause marked hyperglycemia. Finally, the thyroid hormones triiodothyronine and thyroxine, commonly known as T3 and T4, are secreted by the thyroid gland. They raise glucose levels by stimulating glycogenolysis. To help remember the hormones that increase serum glucose, use the phrase GAG TECH. The first part, GAG, stands for Glucagon, which raises glucose by stimulating glycogen breakdown. ACTH, or adrenocorticotropic hormone, which increases glucose and acts as an insulin antagonist. Growth hormone, which opposes insulin and in excess can cause hyperglycemia. The second part, TECH, stands for thyroid hormones, T3 and T4, which increase glucose by stimulating glycogen breakdown. Epinephrine, which raises glucose by stimulating glycogen breakdown and can cause hyperglycemia in adrenal tumors. Cortisol, which increases glucose through gluconeogenesis. Human placental lactogen, a hormone from the placenta that antagonizes insulin. So, when you think of hormones that cause an increase in serum glucose, just remember the easy mnemonic, GAGTECH. The cause of diabetes is either a decrease or absence of insulin production, or a decrease in the body's sensitivity to insulin. The symptoms are easy to recognize. A diabetic patient often feels tired and fatigued. They may experience polyuria, which is excessive urination, along with increased thirst and hunger. Poor wound healing is also a frequent problem. Laboratory testing reveals elevated glucose levels in both serum and urine, as well as an increased hemoglobin A1C level. Cholesterol levels may also be increased in some cases. In diabetic acidosis, several electrolyte imbalances occur. Sodium levels decrease, potassium levels increase, and chloride levels decrease. In addition, ketones are present in both blood and urine. To diagnose diabetes mellitus, we rely on fasting plasma glucose, oral glucose tolerance testing, and the hemoglobin A1C test. For normal values, fasting plasma glucose should be less than 100 milligrams per deciliter. The 2-hour oral glucose tolerance test should be less than 140 milligrams per deciliter. The hemoglobin A1C value should be 5.6% or lower. For diabetes mellitus, fasting plasma glucose is 126 milligrams per deciliter or higher. A casual plasma glucose level of 200 milligrams per deciliter or more, combined with symptoms like unexpected weight loss, excessive urination, or excessive thirst, also indicates diabetes. The 2-hour oral glucose tolerance test confirms diabetes if the value is 200 milligrams per deciliter or greater. An A1C value of 6.5% or higher is also diagnostic. For prediabetes, fasting plasma glucose falls between 100 and 125 milligrams per deciliter. The 2-hour oral glucose tolerance result is between 140 and 199 milligrams per deciliter. The A1C range is from 5.7 to 6.4%. The oral glucose tolerance test has specific guidelines. The standard adult dose is 75 grams. For children, the dose is 1.75 grams per kilogram of body weight, up to a maximum of 75 grams. In pregnancy, for gestational diabetes screening, a 50-gram dose is used. If the 1-hour glucose is 140 milligrams per deciliter or higher, then a 100-gram dose is administered, and fasting, 1-hour, 2-hour, and 3-hour values are measured against established limits. Hypoglycemia is classified into 3 levels. Level 1 is called the hypoglycemia alert value. At this stage, blood glucose is less than 70 milligrams per deciliter. This is the point at which action should be taken to prevent progression. Level 2 is clinically significant hypoglycemia. At this level, glucose drops below 54 milligrams per deciliter. This is a dangerous threshold indicating a true hypoglycemic state. Level 3 is severe hypoglycemia. Unlike the other levels, there is no specific glucose threshold assigned. Instead, it is defined by the presence of severe cognitive impairment, where the individual requires external assistance in order to recover. By understanding these levels, clinicians can take appropriate steps to prevent mild hypoglycemia from progressing into life-threatening severe hypoglycemia. To monitor diabetes, several laboratory tests are used, each with a specific clinical purpose. The first is hemoglobin A1C, also called glycosylated hemoglobin. In this test, glucose attaches to the N-terminus valine of hemoglobin A. It reflects the average glucose level over the past 90 days, or roughly 1 to 3 months. Results are expressed as a percentage and can be converted to estimated average glucose. This test is widely used for the diagnosis of diabetes. However, it may be inaccurate if the patient has an abnormal hemoglobin pattern. The second test is fructosamine, or glycated albumin. This measures glucose attached to total glycated proteins, including albumin. Unlike hemoglobin A1C, fructosamine reflects intermediate-term glucose control, showing the average glucose level over 2 to 3 weeks. The third test is urinary albumin, which was previously called microalbumin. This test detects small amounts of albumin in urine, making it useful for assessing early renal damage in diabetic patients. Finally, C-peptide is measured. When proinsulin is cleaved, it produces both insulin and C-peptide. Measuring C-peptide reflects the patient's endogenous insulin production. This helps determine whether the patient is still producing insulin naturally or is only receiving insulin from therapy. Together, these tests provide a comprehensive view of how diabetes is being controlled and whether complications are developing.